The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everybody. My name is Rob, and welcome to the Understanding GERD and Stretta Therapy Online Education webinar. We're glad you're able to be here and spend some time with us this evening. Before we get started, I want to make sure everybody can hear me. So if you look at that GoToWebinar utility, usually on the right side of the screen, there's an icon there that looks like the palm of a hand. If you can hear me okay, could you just please click on that once? Great. I see some hands going up. Thank you for that. So tonight we're going to cover a few different things here. We're going to talk about what is GERD, how it may be treated, including what Stretta is and how it works and how it can help treat your GERD. Then we're going to talk a bit about what to expect both during the procedure as well as after the treatment, before taking a look at a patient case study and then some of the results that you may that have been had with Stretta. Then we're going to finish up this evening with a Q&A session. So tonight to talk to us about GERD and Stretta is Dr. Gary Reiss. He is with the Louisiana State University Health Sciences and Metropolitan Gastroenterology Associates. Evening, Dr. Reiss. How are you this evening?
Hi, Rob. How are you doing?
Good, good. Glad to do another one of these with you. It's been enjoyable, so I'm looking forward to another nice night. So before we get to your part of this, we want to find out a little bit more about our audience. So if you could all take just a quick moment to answer the poll that's popping up on your screen there. We want to find out how long you've been dealing with your chronic symptoms of GERD. And while you're doing that, if you look back to that GoToWebinar utility, you're going to see a little feature that looks a bit like a chat box. At the end of tonight's presentation, we're going to be doing a bit of Q&A with the doctor, so please feel free to enter your questions in there at any time. We'll get to as many questions as possible in our allotted time tonight. And please do feel free to enter them at any time because I hate for it to get to the end and we forget what your question was. So please feel free to enter those. All right, so let's see. We got just about everybody's voted on the poll. We'll give you all just a few more seconds here. And again, don't forget to visit us at stretta-therapy.com. You can find out more about Stretta Therapy as well as find out about the provider closest to you, or you can always just get a hold of us and we can help you do that. Our phone numbers and stuff will be on there as well. All right, I'm going to go ahead and close the poll and share the results. So it looks like most of our audience, doctor, has been dealing with their GERD for quite a while, greater than 5 years.
So, Rob, this is what we tend to see with GERD. It's a chronic condition, and most people who come to see me, have been suffering with this for quite a while. Just to give you a little bit of my background, I've been a faculty member at Louisiana State University Medical Center here in New Orleans for the better part of the last decade. And I've also been in private practice at Metropolitan Gastroenterology Associates for about the last decade. We have been providing the Stretta procedure for reflux and specialize in some of these patients who suffer with complex long-standing disease. Just to sort of explain the disease process a little more, we saw that over half the people who responded there have been suffering with this condition for more than 5 years. That's because GERD is a chronic condition. It is when the muscle between the stomach and the esophagus is weak, the so-called lower esophageal sphincter. It's a round muscle that opens and closes, meant to keep acid in the stomach where it belongs. When that muscle is weakened, stomach contents, acid, bile, food, digestive enzymes, whatever, can come back up into the esophagus, into the chest, sometimes as high as the back of the throat, and cause symptoms of gastroesophageal reflux disease, or GERD. Now, everyone gets some regurgitation on rare occasions. If you gorge yourself at a Thanksgiving meal, you probably suffer that night. GERD, however, is when you have chronic symptoms, usually occurring more than twice a week and lasting for a prolonged period of time.
All right. Well, thank you, Doctor. Thanks for the introduction and everything. I'm just going to go ahead and turn things over to you. Just let me know when you're ready to change from slide to slide.
We'll go through some of the GERD symptoms first. Thanks, Rob. Persistent heartburn is the most common condition. That's burning pain right behind the sternum that will often sort of migrate up towards the back of your throat. Acid regurgitation, where you have actually an acidic taste or a foul taste in the back of your throat, is also a common symptom. Some people suffer from chest pain. This can be due to caustic injury, that is direct damage from acidic contents in the esophagus, or it can be due to spasm of the esophagus. That is, a little bit of acid washes into the esophagus, The esophagus, being a long tubular muscle, clamps down, it squeezes, creating chest pain that's very similar to a heart attack. Chronic cough is another symptom we sometimes forget about. If you think about where the regurgitated substances go, where the acid, the bile, the food, and so on go, it rises up to the back of your throat. If you're sitting upright like I am now, that might not be such a big problem. If it's 2 in the morning and you're lying flat, the contents can come all the way up to the vocal cords and cause some irritation. Your body's reaction to that, try to cough and clear the throat. Hoarseness or laryngitis is another possible symptom of GERD. You know, the constant hoarse voice, due to a similar mechanism. That is that acidic contents, bile, food, what have you, winds up in the back of the throat. Now, if you take this a step further, there are other symptoms that can be related to problems up here. You can affect the vocal cords, but you can also get into the upper airways, which can result in asthma, also what we call cough variant asthma or nocturnal asthma. And then sometimes you can have so much irritation of the esophagus and so much spasm of the esophagus and sometimes frank esophagitis or inflammation that you can have pain with swallowing or trouble swallowing, sometimes due to a stricture, that is a scarring or narrowing of the esophagus, and sometimes just due to irritation of the esophagus itself. We can move on to the next slide. So, GERD, a common enough condition, many of us suffer with it. The question is, how do we treat it? Most people are somewhat familiar with proton pump inhibitors, or PPIs, even if they don't know them by that name. Some people have heard of the purple pill or seen ads on TV for Larry the Cable Guy and him suffering at the county fair. Whatever. Proton pump inhibitors, the most common medication out there. They are commonly prescribed for reflux and are now actually available over the counter. Now, these work by reducing the amount of acid produced by the stomach and therefore reducing the amount of acid available to reflux into the esophagus. They mask symptoms. They don't really fix the reflux. They reduce the acid. Now, for most people, that's great because the acid is caustic and irritating and causes many of the symptoms. But for people who are suffering from bile reflux or from the food or digestive enzymes produced by the stomach from the regurgitation of those substances, proton pump inhibitors might not solve all the problem. Now, interestingly, in my practice, we're seeing more and more people who are coming in who are concerned about the medication. If you spend just a little bit of time watching daytime TV or surfing the internet, you will quickly find that there are lawyers already with ads out there for people taking long-term chronic medications, proton pump inhibitors included. There are significant side effects in a very small number of patients, and they can have some interference with other medications. Now, I don't want to tell you that proton pump inhibitors are bad medications. For most people, they are fine, and for short-term use, they're really ideal. It's long-term use, and for people who have other medications on board, that there can be some issues. On this slide, we're quoting a journal article from the Journal of the American Medical Association, but there are many others, and it's now sort of the knowledge is more diffuse and is in the New York Times, Washington Post, whatever. Let's move on to the next slide. So when we think about what treatments we have for GERD, for gastroesophageal reflux disease, we mentioned the most common treatment, and that's medications or proton pump inhibitors, the purple pill or other medications similar to this. And most people get a response to this. About 70% of people will have a response. Now, that said, about 30% of people do not get a complete relief, from proton pump inhibitors. The question is, what can you offer those people? In my practice, it breaks down to, we offer Stretta for a large number of those patients who have refractory reflux or don't want to take medications or can't tolerate the medication due to side effects. And then a small number of patients who have severe disease and are not amenable to Stretta treatment, we can offer more aggressive but very efficacious treatments, and those are surgical treatments. Transoral fundoplication is an option. Surgically implanted devices, rings that go around the esophagus to augment that weak sphincter muscle, certainly an option. And then laparoscopic fundoplication, probably the most common and most used surgical technique. That's where the surgeon makes some incisions with a laparoscope, so sort of keyhole surgery, and is able to wrap part of the stomach around the upper portion of the esophagus. In general, most people don't want to take pills lifelong, but they don't really want to jump all the way to a dramatic intervention like surgery. Stretta sort of fills that gap where you can do something endoscopically, something that's minimally invasive, something that can be done, in under an hour, and you can go home the same day. So Stretta is sort of that middle ground between taking a pill daily and having a major surgical procedure done.
All right.
Okay, we have a poll question.
Yeah, we're going to do another quick poll before we start going into what Stretta is. We want to find out what folks' main reason is for considering Stretta therapy. Maybe it's due to those medications no longer helping their symptoms, or maybe you just don't, like the doctor was saying, maybe you're not ready for that drastic or dramatic change of doing a surgery. So remember, while we're doing that as well, don't forget you can go ahead and submit your questions at any time. We do have a few coming in already, so we will be having that Q&A session towards the end of the session, and we'd be glad to get to as many of these as we can. While we're kind of doing this, Doctor, is there, you kind of mentioned the options for the surgery. Is there anything about these surgeries that would prevent somebody from, if they've already had that option, from considering Stretta as well?
So the nice thing about the Stretta procedure is you can perform Stretta in a patient who has had surgery. You can perform it in a patient before surgery. So the idea is you can do it before or after. Stretta is not contraindicated in a patient with a prior fundoplication, and is an option for patients who have had a fundoplication and might not still have the response from that operative intervention.
All right, and you can see we have almost a straight even mix of answers for across the different options here tonight. I don't think we ever had it quite so even.
Well, that's perfect. Well, they're all reasonable concerns. There are a lot of people who, about a third of people who don't have a complete response to acid reflux medications, and the reason they don't have a complete response is, as we mentioned, it's gastroesophageal reflux disease. It's not gastric acid reflux disease. We have substances in our stomach other than acid. We have bile, food, pepsin, a major digestive enzyme, as well as a mix of other chemicals. And patients don't all tolerate medications or don't want to take them. So, it seems reasonable to have a split like that. Now, that said, we're talking about Stretta is still in a treatment gap, but I really haven't told you what it is yet. So we might as well move on to what is Stretta. So Stretta is a non-surgical outpatient procedure, and I should say it's an endoscopic procedure, which means it's done with an endoscope through the mouth, so no incisions, that treats the underlying cause of GERD. If you remember, we talked about that sphincter muscle, opens and closes right where the esophagus joins the stomach. That muscle that's become weak over time from stretch and our Western diet, that muscle, we go ahead and work on that weak muscle to help it regenerate and strengthen. Stretta has been shown to significantly reduce GERD symptoms, to eliminate or decrease medications. So most people can get off proton pump inhibitors and other medications, and even patients who still use them occasionally don't need to use them daily. So very powerful benefit. It has been shown to decrease esophageal acid exposure. So when you work on that muscle, when you improve the strength of that muscle, it creates a more effective barrier and prevents acid from regurgitating from the stomach into the esophagus. And perhaps most importantly, Stretta has been shown to improve the quality of life of patients who suffer with horrible reflux disease. Move on to the next slide. So the Stretta procedure is performed via catheter. So the top picture of the patient with a sort of white tube going into his mouth, that's the actual Stretta catheter. We first do an endoscopic evaluation, so we put a small flexible scope down with a light and a camera on it. We look around the esophagus and the stomach and the small bowel, and make some measurements and figure out exactly where we're going to place this catheter. We then go ahead and remove that scope and then place the catheter in. At the tip of the catheter, which is displayed in the bottom image, is a balloon. We inflate the balloon. There's small thermal probes that are that then come out of the balloon and are sort of embedded into the muscle layer of the esophagus, and we're able to apply radiofrequency energy to help that muscle regenerate. We do that at multiple levels throughout the esophagus and into the top part of the stomach to help stimulate muscle growth and muscle healing. In general, this is an outpatient procedure. It almost always takes less than an hour. We can use conscious sedation, that is a very light sedative where we can give you a good shake and wake you up. Not that we would want to do that, but we could. Or we would give you general anesthesia where you're completely sedated. Depends on particular clinical situation. We do the upper endoscopy, we place a Stretta catheter, we go ahead and then apply the radiofrequency energy. You can move on to the next slide. So all those little white dots in the top picture show where the actual radiofrequency energy is delivered. So we deliver multiple levels throughout the lower esophagus. We know from a variety of animal models, studies in humans, randomized controlled trials, physiologic studies, whatnot, that radiofrequency energy stimulates muscle to grow over time. So the idea is to regenerate a damaged muscle. Now, once the sedation wears off, we go ahead and apply the treatments, 30 to 45 minutes of work there, and then, maybe 15 minutes, check you out after. We then let the sedation wear off. Once you are, fully recovered, we let you go home. You're on a modified diet that day, soft foods, things of that nature. But in general, most people resume activity the following day. Now, the treatment goal with all this is a thicker muscle. Okay, if the esophagus, if that muscle isn't thick enough, it can't create a tight seal. So we thicken the muscle, which improves the barrier function and prevents regurgitation of stomach contents. So if you think about it intuitively, that is a sort of not only a more physiological or more natural approach, keeping stomach acid in the stomach, but you're also treating more than just acid. If you think about that purple pill and its close cousins, those reduce acid production. The Stretta procedure does not affect stomach acid. We're supposed to have stomach acid. It helps, protect against certain pathogens. It helps begin digestion of food. What the Stretta procedure does is prevent regurgitation of stomach acid, bile, food, pepsin, whatnot, into the esophagus, pepsin being a digestive enzyme. And go ahead and move on to the next slide. Now, I wish gastroenterologists could claim that they had come up with radiofrequency energy, but we are just borrowing it from other fields in medicine. The healing power of radiofrequency energy is well established. Radiofrequency energy is widely used in healthcare. Cardiologists use radiofrequency energy to treat atrial fibrillation. Urologists use radiofrequency energy for treating prostate enlargement. ENTs, as your head and neck doctor, will use radiofrequency to eliminate snoring and to treat sleep apnea in certain cases. In addition, radiofrequency is used in cosmetic procedures for body contouring, skin rejuvenation, and tightening of the skin. And truth be told, the Stretta procedure probably shares most in common with its with our colleagues in dermatology as far as where the procedure is borrowed from, or in its similarity to other procedures. That is, we're trying to remodel and tighten a muscle and underlying collagen and other supportive elements of the soft tissue matrix surrounding the muscle. Animal studies have shown that technology used in Stretta may increase smooth muscle and improve collagen in a treatment zone in the area that's treated. So what we think we're doing is not just improving the muscle, but all the structures around the muscle, sort of creating a sort of a tightening and a more functional grouping of the muscles based on the surrounding collagen, if that makes sense. So we can go ahead and move on to the next slide. Now, while animal studies and physiologic models are great, the proof is really in patient outcomes. And when you're evaluating a treatment for reflux, you really want to know that it's been tried, that there's a track record, that a lot of patients have had benefit from it. Luckily, Stretta is widely studied. There have been more than 20,000 Stretta procedures performed, and it's sort of like that McDonald's sign, right? Just keep updating the numbers on there, but it's probably more like 25,000 now. But in any case, many Stretta procedures have been performed. At least 40 clinical studies conclude that Stretta is safe and effective. The complication rate is low, far less than 1%, and really similar to basic upper endoscopy. To put that in perspective, that's safer than a colonoscopy, and an endoscopic test that everyone in the country is recommended to get with rare exclusion. If you look at patient satisfaction, if you ask people who've had a Stretta, would you have this done again? The response rate is 93%. So unfortunately, we're missing 7%, but still 93%, that's pretty good, better than what we get in our surgical literature. So pretty impressive data. Now, you also want to know when you have a treatment that's going to last for a while. Most treatments for reflux, unfortunately, don't last forever. And the reason is that the underlying cause of that weak esophageal sphincter muscle, it's what we do to ourselves. Our diets are not the the most conducive to long-term gastrointestinal health. If you overeat, you stretch the stomach and you stretch the sphincter muscle at the top of the stomach, which can induce a bit of scar tissue development over time. So, that said, given that you can't have damage to the sphincter muscle, what is the long-term efficacy of Stretta? How long does it last? Well, we know we have 4-year data showing that close to 90% of people are off their daily proton pump inhibitors. We know we have 8-year follow-up of saying that 70% of people are off their daily proton pump inhibitors, and we know we have 10-year follow-up showing that almost 70% of people remain off of. Somewhere between 60 and 70% people remain off proton pump inhibitors. So there are some people who fall off and need to have repeat treatment. That said, most people, if they have a response to Stretta, will maintain a response to Stretta going forward. Let's move on to the next slide. Rob?
Is that not refreshing for you? Oh. Should be what
here
to
we go.
expect.
Okay.
There we go.
I got it. Yep.
A little slow tonight.
Yeah. Well, we have it here. So, a lot of patients, understandable question is, what are they going to expect after the Stretta? If we go ahead and do this, what is response? Well, it is an endoscopic procedure, and we are going ahead and providing a lot of directed energy to the muscle of your esophagus. So you're not going to feel normal after, but it's not going to be that bad either. That day, you should expect to feel very tired and take it easy. You won't be able to drive yourself home. You won't be able to, exert yourself. We tell people to go home, watch TV, take a nap, something along those lines. Now, most of that's probably the anesthesia we use, but still, it is, physiologically taxing. Excuse me. The most common side effect is a sore throat or mild chest soreness, and that's usually resolved within a week, usually 1 to 5 days. Sometimes people feel bloated. They will have some increased belching and gas. The reason for that is there's some swelling in the lower esophagus, making it easier for gas to get trapped in the stomach, and eventually that gas has to vent, and that comes out as some belching or some gas. Most people can resume normal activity the following day, and that's very important for many of my patients because surgery can knock you out for keep you in the hospital for a couple of days and leave you not at full strength for 6 weeks or whatever. So it is important for them. So then you can return to work the following day. Now, post-procedure instructions are provided, and they're somewhat specific. Avoid food with sharp edges, toast, potato chips, stuff like that. Stick with soft food, liquids the first day, so on and so forth. So we have some specific instructions that we do provide you. Now, again, we are providing energy during the initial treatment that is directed at the muscle layer of the esophagus. It takes time for the muscle to heal. We are sort of jump-starting that process. So I tell my patients that they want to continue their acid suppression medication for at least a couple of months before we can wean off the medication. GERD is a long-term problem. It's something that's existed in most patients, at least on tonight's webinar, for over 5 years. And it's something that we want a long-term fix for, and that can take a little time. So a couple of months more of acid medication is the norm for most patients. That allows the muscle some time to thicken, allows that barrier function some time to kick in. And then after a couple of months, we wean patients off the proton pump inhibitors. So you start taking the medication every other day, then maybe every third day, and then you stop it. Let's move on to the next slide. Okay. Now, as I was alluding to, you really can't expect your symptoms to improve immediately. We know from the randomized controlled data out there that most people have improved quality of life scores, after 2 to 3 months, and that acid exposure in the esophagus appears to really plummet sometime between 6 and 12 months. So you keep getting an improvement all the way up to that first, through that first year. The effects do develop slowly over time, and it's very variable. Some patients improve in a couple of weeks. Other people take 6 months, but most people do get the improvement that they were seeking. So most patients, we wait about 2 months, sometimes 3 months before we wean you off the medication. And most patients by that time have started to see an improvement. That said, in a small number of patients, it might take as long as 8 to 12 months. So give it time and see how you do.
All right, we got a quick pause for another poll. Before we move on, we just want to find out what previous options you've tried to control your GERD And I'm sure a lot of you have probably tried multiple options, so maybe let us know what the most recent one is that you were tempted. While we're doing that, we've got a few clarification or questions coming in. So you talked about a little bit about taking it easy after the procedure. Fran's wondering, is this going to affect her daily yoga practice? You know, how the body can become twisted in various poses and things like that, and also other exercise, like she does race walking for exercising and running. Is it going to affect any of that, having the Stretta?
Right. So unlike surgery, there's no alteration of the anatomy. The goal is actually to restore what, previously what should be there. So now you can go ahead and resume the following day. You can resume pretty vigorous activity, as long as you're not in pain. So it should not limit yoga. It should not. I've had other people who are fitness buffs, and I tell them they can go back to the gym the following day. So she should be just fine.
All right. So it looks like our audience is kind of split between diet and lifestyle changes and medications for their attempts for controlling their GERD.
Sure. Okay. So we have people early on in their disease. So this is if we sort of restructured how this poll response looks, it really should be a pyramid where you start with diet and lifestyle changes, and most people do that, and then a smaller number move on to medications, and a smaller number at the very top move on to surgery. So diet and lifestyle changes are always the first step. And what do? We try to eat smaller meals, maybe lower carbohydrate meals. We avoid really heavy, greasy meals right before bed. We try to eat earlier in the day. Healthy living will reduce reflux in many people. Extra weight, particularly around the mid part of the abdomen, will compress the stomach and worsen regurgitation just by direct compression of the stomach. The contents have to go somewhere. And medication is the next step for patients. So the advantages of Stretta, is that if the medication doesn't work and the diet changes haven't worked, we don't really need to jump all the way to surgery. So it's that middle option that fits between medication and surgery. It's non-surgical Stretta. It's endoscopic. Remember, we put that catheter through the mouth, down to the esophagus, the balloon inflates, and then from the tip of the balloon, we're able to go ahead and apply radiofrequency energy. It has it's not non-surgical, it's an outpatient procedure. I should mention you do go home that day. Very low complication rate, significantly less than 1%. It does not alter your anatomy. So if you think about what we do with other techniques, we take the stomach and try to wrap it around the esophagus. That's not a normal position for your stomach to be in, and it's not a normal structure there. So that does predispose to different problems. Stretta does not do that. We do not alter any natural anatomy. We, in fact, just aim to induce your body's own healing mechanisms. Stretta is widely studied with long-term follow-up. There are other techniques and treatments out there, but you really want to know that something has 4-year data, 8-year data, 10-year data, because the Stretta procedure does have studies that extend that long. And then, a nice thing when we're dealing with insurance companies is that it's cost-effective when compared to long-term medications, and cost-effective certainly when compared to dramatic interventions like surgical interventions. So, what is Stretta patient profile? Who is the ideal Stretta patient? Well, patients who don't respond completely to medication, certainly, and who are seeking some other alternative to augment medication. There are patients who have drug interactions with or are intolerant to proton pump inhibitors. There are patients who are concerned about side effects of long-term proton pump inhibitor use. So in the short term, about 1% of people will have headache or diarrhea or something like that. But long-term, people are concerned about is there an effect on the kidneys? Is there an effect, on the heart? There have been concerns about infection, bone loss. There's been some articles of questionable validity about correlations with dementia. So that, there are concerns about long-term proton pump inhibitor use. Patients who wish to avoid anti-reflux surgery are ideal Stretta candidates. That is, they really want to do something for their reflux. They just don't want to be cut on, and I think we can all understand that. There are patients who experience non-erosive reflux disease, or NERD. That's where they suffer with reflux, but it doesn't actually create large erosions in the esophagus. Those patients do have a good response from Stretta and would be reasonable candidates for this. There are patients who suffer from respiratory reflux symptoms or laryngeal-pharyngeal reflux, cough, asthma, hoarse voice, things of that nature. Some people can have recurrent earaches or dental erosions, all sorts of things from reflux all the way up to the back of the throat. Stretta does a good job of reducing proximal reflux, that is a reflux that comes very high into the esophagus, and because it reduces other digestive enzymes, seems to be particularly good for patients who suffer from these airway-related or respiratory-related symptoms. Patients who have had anti-reflux surgery, maybe you had a fundoplication or some other surgical procedure in the past, you initially had a response, that response has begun to wear off, the question is what to do now. So there are many patients out there who have had a fundoplication, a traditional surgical treatment for GERD. The initial fundoplication, surgeons do a spectacular job, it's low risk, people have a good response. The problem is when it breaks down, and about half of people have recurrent reflux after 5 years, so it does break down. What can be done in that case? A redo fundoplication is much riskier, much more technically demanded for the surgeon, and carries greater complication. So patients who have had anti-reflux surgery, ideal candidates for Stretta. Sort of low-hanging fruit. Those patients will get better. You'll escape having a very risky operative intervention, and then everyone's happy. So good candidates. And an interesting group, a lot of people now are having bariatric surgery or weight loss surgery. One of the most common procedures we're seeing for weight loss surgery is called a gastric sleeve or a gastroplasty, a vertical gastroplasty. In this procedure, part of the stomach is removed, and that precludes or just prohibits many of the traditional surgical treatments for reflux. You can't wrap the stomach around the esophagus as part of the stomach is missing. So in those patients, they're really, if they're having reflux, there's really no option other than Stretta. So great option for bariatric surgery. Looks like we missed a slide there. All right, perfect. Now, there are contraindications for Stretta, not many, but some that are important. Patients under age of 18, this just hasn't been studied in younger patients with reflux, and the disease really is different there. Pregnant patients have horrible reflux. That said, it can often be waited out. You can often wait it out, and most reflux does improve after childbirth. Not all, but most patients get better. Patients without a diagnosis of GERD, and that would seem sort of obvious, but sometimes those symptoms just aren't clear. You can have throat clearing for many reasons. You can have heartburn that can be due to acid reflux, or it can be due to your heart. So many times we do have to run some confirmatory diagnostic tests to either measure acid exposure in the esophagus or evaluate the esophageal contractility, or how the stomach functions, or whatever, to confirm that you do have actual reflux, severe reflux that correlates with your symptoms prior to actually performing the Stretta procedure. And those are the same sort of tests that we might get before a surgical intervention for reflux. Patients with a hiatal hernia that's pretty large. Now, hiatal hernia is where the stomach, instead of staying tucked down below the diaphragm, herniates up into the chest, herniates through the hiatus or opening of the diaphragm. And that stomach will slide up to down, and cause all sorts of symptoms. If that's a small herniation of about 2 centimeters, and that's something your doctor would measure either during endoscopy or with a special type of X-ray called barium esophagram, that's no problem. We can treat that. A larger hiatal hernia, though, really you wouldn't get the benefit you'd want from a Stretta, and you do better with a surgical intervention at that point. The hiatal hernia is one of the most important things to evaluate for prior to the Stretta procedure. There are diseases of the esophagus that can mimic reflux or cause reflux that would preclude you from Stretta. Achalasia is a disease where the lower esophageal sphincter doesn't relax and the esophagus above that doesn't contract. That results in sort of a saccular dilation or an expanded swollen esophagus where food contents just sit and regurgitate. In that case, Stretta would not be helpful, might be even harmful, one could imagine. So you would want to go ahead and have that evaluated for prior to undergoing Stretta. There are other diseases similar to achalasia, what we call connective tissue disorders, that we sometimes evaluate for prior to Stretta. Finally, if you've been told that you're a poor surgical candidate, that might indicate that you're not a good Stretta candidate. And the reason is that many of the risks of surgery are not so much from the surgery itself, that it's not from the scalpel, but from the anesthesia, the big mask, the gas that they give you. Given that we use some form of sedation during the procedure, we would need to have you closely evaluated and make sure you are a reasonable candidate for the anesthesia provided during Stretta. So I'll take a moment and just talk about one of my early patients, and one of the times I got really, the first time I got really excited about this. This is Sharon. She's a 53-year-old woman. She had chronic GERD for many years. She was taking daily proton pump inhibitor medication, and that helped most of the time, but not all the time. She had breakthrough symptoms. She wasn't able to go out to eat with her friends, and really, really impacted her quality of life. She came from Mississippi. I'm based down in New Orleans. She had about a 4-hour drive. And, I told her, just come back if you have trouble, and, I'll talk to your gastroenterologist back at home, and he can follow up with you. Anyway, she drove back, and I saw, the chart at the door, and I saw she was there, and I was like, oh, no, what's going wrong? She hasn't gotten better. But I walked in, and, I immediately got a big hug. Turned out her symptoms, which included heartburn after meals, nocturnal reflux, cough, interrupting her sleep for years, they had sort of ended after Stretta. She was feeling so great, she wanted to, come back and thank me in person. And, that's the sort of story you hear pretty commonly with Stretta. Now, as she was walking out the door, her husband then grabbed me and gave me a hug, and I did not see that coming. He was a big, burly guy, and I was not expecting that bear hug. Well, it turned out that he was super thankful because not only was his wife sleeping, but he was sleeping now as well. One of those things you don't often think about, but you can treat 2 patients with 1 Stretta on rare occasions. So, anyway, satisfying patient experience. We often don't think about how disruptive reflux is for sleep. In any case, when you really get down to it, for people with GERD who need alternative medications or surgery, Stretta is really that answer. It is the next wave in GERD treatment.
All right, helps if I take myself off mute. All right, so we got one last poll question for everybody. We just want to find out, now that you've learned a little bit more about Stretta, what's maybe the most appealing aspect about it for you so far? The fact that it's non-surgical, the history behind it, the fact that it may actually be something that can help you out, things like that. So we still got some questions coming in. So again, turn your attention to that GoToWebinar utility. There's a lot of great questions here, but we can still take more. We're going to be getting to our Q&A session here shortly. But we have a quick question here that, Dr. Reiss, you were just talking about the situation with the hiatal hernias. Bill said that, is there anything that can be done if it's just minor? And because he's trying to avoid 2 procedures, one to check for the hernia, before that, or is there some other non-invasive test for that hernia? You kind of alluded to that a little bit. If somebody were to come to you in a situation where they're not sure if they had a hiatal hernia, how would you help diagnose that for them to see if they're a candidate for Stretta?
Sure. So there are 2 options to evaluate the hiatal hernia. The most, I guess, the most accurate and most useful for the person performing the Stretta is for an endoscopy to be performed, where you put a scope down and take a look. That said, if you're trying to avoid that particular test, the alternative is what's called a barium esophagram. Barium esophagram is a very simple test. It's quick, doesn't require sedation, cheap, easy. You swallow some barium, which is sort of a white, chalky substance that shows up well on X-ray, and the radiologist who performs the test watches what you swallow and watches it enter into the stomach. And that provides a lot of information about sort of how much content is reflux and also how much of the stomach is moving up into the chest. It's not a perfect test. It's old technology from the 1930s, but it is often more than enough for our purposes. So 2 tests: endoscopy, that's taking a look with a scope with a light on it and sort of seeing what's going on down there, or a barium esophagram.
All right. So in that, if somebody does have, like the minor hernia, you mentioned if it's 2 centimeters or less, they could be a candidate. What about for somebody that maybe has a larger one? Can they maybe get that fixed and then have a Stretta?
Sure. So there are options. So the truth is, in my practice, I can't. If it's a little larger than 2 centimeters, we can often get away with it. Now, that said, the official word on this is 2 centimeters, and most doctors will stick to that. But occasionally, you can get by with a little larger, maybe even up to 3 centimeters. If it's a very large hernia, really the best treatment for that is to have the hernia repaired by a surgeon. Now, a lot of times, the surgery they do will fix the reflux because a large hiatal hernia is, a cause of reflux. Oftentimes, though, if you're going to go through that surgery, having the fundoplication done at the same time is reasonable. That said, we have many patients who have had surgery to fix a hiatal hernia and their symptoms haven't improved, and then we go ahead and do the Stretta after that. So you absolutely can have your hernia fixed and have a Stretta done. It sort of depends on the practice of the surgeon and of your gastroenterologist.
All right. So looking at the poll results here, it looks like the majority are hopeful that this is something that might actually fix their reflux problems. Especially if you kind of look at that, if they're the same folks that are currently on the medications versus just, like you said, masking those symptoms instead of actually treating the problem.
Yeah, well, I'm glad people are excited about fixing the problem. My appeal to all the studies out there apparently didn't sway many people, but it is something that will fix the reflux problem, and it is something that's non-surgical, widely studied. And if you're in that small 7%, you don't get the response they want. It doesn't preclude other options, which is very nice.
Okay. All right. So that's going to kind of lead us into our Q&A session in general. So again, we've got a few questions here ready to go, but we're going to have time to hopefully get a few more. We've got roughly 20 minutes left in our scheduled time here. So Blake was one of our first questions that came in earlier. He said he flies weekly for his job, and he's concerned about the time frame of recovery. Is there any sort of travel restrictions for that first week or two after surgery, or I guess after the treatment?
No. The nice thing about Stretta is you're back on your feet very shortly after. Last week I had a patient who is a food critic. He travels the world actually, and writes reviews new restaurants. And if you read the New York Times or GQ or any of these magazines that often have articles about the top new restaurants, that was someone I was taking care of. And obviously for him, reflux is an occupational hazard, and he has to travel. I told him to give me 3 days just to make sure. But the truth is, he could have traveled the day after. So, what will be the restrictions after? You might have a little soreness right here, sort of the solar plexus, so to speak, the bottom of the sternum. You might have a little bit of discomfort when swallowing, some increased, gas trapping, and occasional need to burp or belch. But those are all minor. I give people some pain medication. Probably less than half the people take it. Tell them to take some liquid Gaviscon or other liquid antacid to help with indigestion. And the following day, you usually are back on your feet. We say that symptoms can last, up to 5 days. Most people, it's probably 3 days or less. If you do travel weekly, it shouldn't preclude that. You maybe get the procedure done on, the Thursday and have Friday, Saturday, and Sunday to recover or something like that.
All right. So we had somebody else, Sam, who's had a surgery, a proximal gastrectomy to eliminate gastric cyst, about a 5 centimeter size, he says. Are these sort of things, after surgery, he's still suffering from GERD, he's still taking PPIs, and I don't know how much we can get into on specific instances of that, but is that something you're familiar with and might be able to see if is Stretta something that might be able to help in his case?
Yeah, it's worth a shot. The function of the stomach can be altered because the part of the stomach that relaxes the fundus is no longer present if he had part of the proximal portion of the stomach removed. That said, while there are no large studies done on patients with partial gastrectomies, people who do a lot of these procedures, myself included, have treated people who are missing part of the stomach, or in rare occasions the entire stomach. We have had improvements in symptoms. So because Stretta is very low risk, and because it should work in that setting, I'd say give it a shot. There are no guarantees, and we don't really have large studies in patients, or any studies in patients who have had that type of surgery, but it should work. Now, the question is, what else could you do? I mean, you can't do a fundoplication if part of the stomach's been removed, so there aren't surgical options. So, while you're sort of between a rock and a hard place, so Stretta would be a reasonable option in that setting.
Okay. Another treatment option, or another prior procedure option, we have somebody here that previously had a mini Whipple about a little over a year ago. I'll be honest, I'm not sure what that is. Hopefully you do. But he's wondering if that would be causing any issues to maybe having Stretta for treatment for GERD.
Sure. So, a Whipple procedure is where you remove part of the pancreas, the gallbladder is removed, the duodenum, and you sort of do a reconstruction there. Part of the stomach might be removed, what's called the pylorus, the sphincter muscle at the other end of the stomach, at the bottom of the stomach, so to speak. Now that should not affect Stretta. You're going to have a hard time finding any surgeon who would want to operate, because usually when a dramatic operation like that is done, there's a lot of scar tissue and adhesions, and it's not easy to go in and operate. So, Stretta should work. I mean, we're working on a different muscle and then sort of in a different part of the stomach and the esophagus. So there really shouldn't be any obvious contraindication. That said, most people who have a Whipple done have a serious underlying condition, and that might preclude Stretta treatment. So, it really depends on the specific treatment or specific condition.
Okay. So you mentioned earlier about how it can take a little while for the full effects of the procedure to really be felt by patients. Oops, sorry, it just scrolled right by me. Have you ever had any, so Mary Ann's curious, so about right afterwards, have you ever had any patients that have had trouble swallowing after their Stretta treatment? Is that related to that sore throat you mentioned?
Sure. Right. So what we call dysphagia or swallowing difficulty is it does occur. It's I can't remember the exact percentage off the top of my head. Less than a third of patients, let's say, will have some discomfort swallowing, some trouble swallowing. Food does not get stuck. It just sort of feels like it's hung up. So the recommendation is soft food, and also I tell patients to drink a large glass of water during their meal. So take a bite, sip, take a bite, sip. And again, that's transient, and it usually lasts about 3 days or so. I had one patient who it lasted significantly longer, and she eventually recovered. So, there are people out there who it can last longer. But I've performed hundreds of these procedures, and I've not had significant swallowing trouble after the procedure long term.
Okay. We've had a few questions regarding insurance and cost and stuff. I know because you're only in, the folk you deal with ones in your area. Can you address just maybe some of the general costs somebody might expect and what insurances may cover this, that sort of thing?
Sure. Now, insurance is tricky because insurance is incredibly local. It really depends, varies state by state. And I'm in Louisiana, so I can only speak for Louisiana. Louisiana, it's not a big deal down here. Our major insurers, the Blue Crosses, the Medicare plans, even the Medicaid plans cover it down here. Now that varies depending on where you are. In some neighboring states, in Mississippi, we have trouble getting coverage. In other neighboring states, Arkansas, we have good coverage. So it really varies state by state. You really have to check. That said, my practice and other practices, you see the doctor, maybe the nurse who checks you in, but there's a whole back office of people who just advocate for you and fight with insurance companies day in and day out. So you'd really have to run it through them. Not all insurance covers it, just like insurance doesn't cover all procedures. And, that's a shame in my opinion, but it is what it is. We have a small number of patients who will, pay out of pocket because it's an outpatient procedure. It's significantly cheaper than a surgical procedure. And that's sort of, something we can use to appeal to insurance companies.
Okay. So probably the best advice on that is to get in contact with one of the Stretta providers closest to you, and they've got that team of folks that can hopefully work with them, check out what their insurance coverage is, things like that, and kind of walk them through the process.
I think that's a reasonable plan.
All right. All right. So Mary Ann was asking a question about how in Pittsburgh there's just not a lot of folks doing a lot of Stretta procedures. The folks she's talked to seem to prefer doing the LINX procedure, and just had some questions about the success rates, thinking that the success was, she heard there was a 50% success rate where, we had that slide earlier that showed we had much better results than that. Do you know why that might be a little misconception there?
Sure. So LINX, first of all, for the other people, LINX are a bunch of, or a series of metallic beads that go around the esophagus. And LINX is reasonable for people who wish to undergo surgery. So, surgical procedures in general work quicker and you get a more dramatic response, but it is surgery. So, if that's right for the patient, then certainly surgery is an option. Stretta, it depends on what you're measuring. We know from the most recent data published a couple of months ago that looked at all the studies out there, one of the largest meta-analyses or largest evaluations of multiple studies that's been done, that more than half of people are off of all medication long term. That is better than what we have for laparoscopic fundoplication. Now, LINX might be a great procedure, but it's brand new. There is simply no way to compare LINX with Stretta because we don't have long-term data on LINX. My concern with LINX is not that it doesn't work. I think it probably works great. I mean, you're squeezing the esophagus. How could it not prevent regurgitation? My concern is how many of them have to be removed because of complications, and we have seen a fair number that has to be removed. We don't have a lot of links down here in Louisiana. It's not covered by insurance here, but it certainly is reasonable to ask your surgeons how many have they had to put in and how many have they had to take out. My general approach is to first offer Stretta, and if that fails, then offer surgical options. Now down here we usually go for laparoscopic fundoplication because LINX isn't available. I think LINX might be what we go to when it becomes more widely available if patients fail Stretta. It certainly is an appealing intervention, but again, it is a foreign body, something metallic that will sit in your chest for the rest of your life, so it's not to be undertaken lightly.
Okay. So Susan, as a follow-up to that, she was asking about recommending somebody in the Pennsylvania area. So Susan, if you give us a call tomorrow at the number on the screen there, that 855-855-3639, we'll try to help do a little research for you with you and try to see who we can get you connected with that's nearby you. It kind of brings up a good point, because we do sometimes have folks that are areas that are quite a ways away from their nearest provider. Is this something that if somebody has to travel a little bit, that is a possibility for them? Like maybe they live a few hour drive away. Is this something where they got to keep coming back over and over for, or?
So yeah, it's usually a one-time shot, and I guess the furthest I've had is New Jersey. Patients do travel for this procedure at times. The actual procedure itself is pretty simple. That said, I had alluded to sort of a pre-procedural workup that we sometimes need to do, and while it's not necessarily a checklist, it does vary patient to patient. We do want to make sure that the right tests have been done. So it is something you can travel for. It just requires maybe a little communication ahead of time.
Okay. So kind of related to that, Norman says his gastrodoc does do or is listed for doing Stretta and hasn't done a lot of them, but Norman, you don't say where you're from, but he's asking, would it be better for him to come and just see you in New Orleans and have you do his procedure?
Well, I'd certainly be flattered, but the truth is the learning curve is pretty easy. I train fellows or young gastroenterologists in this procedure, and I usually make them do 6 under direct supervision, and that's about it. It does not take that many to really get the hang of it. But if you're not comfortable with the volume that's been done, certainly see myself or someone closer. I don't know where you're located, but there are a large number of Stretta providers who are not at all equally divided across 50 states. They tend to cluster in certain areas for whatever reason. But I'd want someone who's done 6 of them at least.
Okay. So we had Jennifer saying she's actually scheduled for Stretta in August. And she's saying that some people have heard that it can actually make the LPR symptoms worse. Is that the case?
No, that's an easy one. No, but
okay.
No. So transiently, you're putting a catheter through the back of your throat, doing endoscopy, which can irritate things. But the only evidence we have for laryngopharyngeal reflux symptoms, and by that we mean cough, hoarseness, and so on, is that people get better. Now, in general, not Stretta specific, but in general, those are the toughest reflux symptoms to treat. So I wouldn't be surprised if it took longer and less efficacy in that setting, but everything does. And from the clinical data that's out there, it's efficacious, and from my own anecdotal experience, the patients who get a good response seem to love it, and most people seem to get a decent response. So.
Okay. She's also wondering if this would help with the globus burning mouth.
Yeah, well, it depends. If that's caused by reflux, absolutely. Now, sometimes we do testing to see, if that's caused by reflux, and we try to measure how high the acid comes, or sometimes we use different monitors to see if there's acid or non-acidic reflux in the back of the throat. Sometimes we do what's called an impedance study, where we see what exactly is in the esophagus at different times. So, without getting into the specifics of this one situation, globus is tricky to treat, and if it's caused by reflux, it can be treated by anti-reflux procedures.
Okay.
You just need to be certain that's the cause.
So I can't remember if we got into any discussion about Barrett's esophagus earlier, but we have Bill in the audience has said he had his Barrett's repaired via Halo 360 about 5 years ago. Would that preclude him from having Stretta?
No, absolutely not. So I treat a lot of patients with Barrett's esophagus. That's damage to the lining of the esophagus that results in sort of a pre-malignant situation or pre-cancer situation. You treat it with a different type of radiofrequency, which is called radiofrequency ablation, where you burn off the tissue of the esophagus. Much more painful than Stretta, but still very manageable. What I do after a halo procedure is if the patient's a Stretta candidate, I actually offer them Stretta, because what causes the Barrett's esophagus? Reflux. If you really want to get to the root problem, and treat the reflux. That said, that's my particular practice, and there's no evidence. There's no study out there that looks at people who've had Barrett's esophagus specifically and how they respond to Stretta treatment. But it's logical to treat the acid reflux after performing halo. So I think it's a very reasonable approach.
Okay. So earlier we talked about how Stretta, and you don't always see the results right away, and that there are that small percentage of folks that maybe don't get the full results. Is it something where you've ever done Stretta twice for somebody to get even better results?
I have a small number of people, probably half dozen or so, who I've had to repeat Stretta on. I know some of the other physicians who perform a lot of these procedures have had to repeat Stretta in a small number of people. It's in the people who are hardest to treat that we wind up doing more than one treatment. And who's the hardest to treat? That sort of borderline size hiatal hernia, or people with mainly laryngopharyngeal reflux symptoms. Sometimes they have to be repeated, but again, that is the minority of patients. Most people, it's a one-time treatment.
Okay. Let's see. So Allison, she had a tonsillectomy a while back, and her surgeon basically told her that the pain would go away in a week. Kind of like how you said tonight that it usually lasts only a few days. Have you ever had anybody where, well, with her tonsillectomy still bugged her 7 months later? Have you ever had cases like that with Stretta where?
I had one patient who suffered for 2 weeks. I think I mentioned that earlier, and I didn't have her esophagitis fully healed before I did the procedure. I probably should have given her a little more time on medical treatment before jumping in. We want to make sure that things aren't too inflamed there. So that's probably the longest I've had for pain. Most people really is 3 days. That said, there are no guarantees in this world. Lightning can strike. It's a straightforward, safe procedure, safer than surgery, but there are always risks with anything we do. So it's possible she would have symptoms long term. It's very unlikely. I send everyone home with pain medication that's enough for 3 days maybe, and I really haven't had anyone aside from that one patient suffer longer.
Okay. Let's see. So we got another quick question about the hiatal hernia situation. And so Joan's asking, she was told she has a hiatal hernia that's moderately large. I don't know if, is that the medical term that would fit into that 2 centimeter range that you were talking about earlier, do you think?
Yeah, I don't know. I mean, there's something, it's a very, very subjective. My hunch is she's probably going to be borderline, between 2 and 3 centimeters or something, but she just had to ask her gastroenterologist. The way we often measure a hiatal hernia for the purposes of Stretta is by the width of the hernia. So we'll put the scope down to the stomach and then retroflex, or turn the scope back upon itself, so it'll look like sort of like an umbrella handle, so we can see where the scope's coming into the stomach, and we sort of make a judgment on how many scopes could fit in that gap in that hernia. Scope being about 1 centimeter in size. So, if the gastroenterologist thinks more than 2 to 3 scopes could fit in that gap, then it's going to be too large. But really, she'd have to check with her gastroenterologist. If she can't get a straight answer, it can be measured on a barium esophagram, which is a quick, easy, cheap test that doesn't require sedation or even an IV.
Okay. That would be one way to just kind of confirm. And again, if at some point it was repaired, even if it was too large, that could be an option down the road, I suppose.
Correct.
All right. So Denise is saying, so you mentioned the treatment is done and normally doesn't require any sort of follow-up. Is follow-up only required if there's any sort of complications or the results just aren't what you were expecting?
Well, for people who live in the area, I have them follow up in about 3 months, 2 to 3 months, to start weaning their medication. But no additional, we don't repeat an endoscopy or get x-rays or anything like that. So it's just a clinic visit. And, I guess that's somewhat optional. I could just give the instructions. For people who live far away, I certainly just talk to their local doctor. So,
okay.
Not much in the way of follow-up.
All right. So speaking of talking to local doctors, Susan kind of followed up with a few things about, she's the one that had the mini Whipple, and she's saying the gastro doctors there have no idea what to do with her. She's seeing somebody tomorrow, and they just have her on the max dosage of PPIs, and that the only thing left is like one of the major surgeries. So Susan, I think try to give us a call tomorrow. You know, he's never, their doctors never recommended Stretta. So I suppose, you know, can you address maybe sort of how well known Stretta is out there as an option for folks? I mean, I suppose a lot of the surgeries are sort of the go-to for some folks, but what about Stretta?
Yeah, I mean, surgery's been around. I mean, that's been the treatment of choice forever. I mean, some variants since the 1950s. We've sort of been stymied by insurance. So you have this weird situation where, you know, some states don't have great coverage, so there aren't that many doctors that perform it, but on the other hand, insurance doesn't want to cover it because there aren't that many doctors that perform the procedure, right? So it's sort of a vicious cycle. So, yeah, that's one issue. The other issue is that until recently, we didn't have that 10-year follow-up data. So now that we do have 10-year follow-up data, the procedure is sort of blowing up. So in some areas, it's extremely well-known. In other areas, it's just not pursued. And, you know, it's sort of hard to break habits. I mean, surgery works, and it's been done since, you know, forever. So a lot of docs do refer directly to the surgeon. You know, that said, it really is worth being an advocate for your own medical care in this situation and seeking someone else who does know about Stretta and really knows sort of what the data says and what the evidence is, and knows about the other procedures that are out there. The procedures that we have, Stretta is the endoscopic procedure with the most data. There are surgical procedures that are exciting that don't have long-term data yet, LINX being the primary one. But you know, all of these procedures that are not standard surgery, you really have to find someone who's an expert in treating difficult reflux disease to, you know, find out information about these procedures.
Sure. So, Susan, and anybody in general too, you know, we've got a few questions. I don't think we're going to get to some of the more specific ones. We're basically, well, basically we're out of time. So we're going to try and squeeze one more question in. But before I do that, give us a call tomorrow, 855-855-3639. We will try to help find somebody near you that is familiar with Stretta and get you connected with them. And I suppose, Doctor, ultimately it may not be the best option for them, but like you said, it's good to be an advocate and at least explore those options.
Absolutely.
All right. So I'm going to finish it off with one last question from Denise, or sorry, not from Denise, from Cindy. You had mentioned the contraindications earlier. There was the one about the hiatal hernia, but there was that other one, I think it was aplasia. Can you maybe just...
Achalasia.
Achalasia.
Sure.
Okay, so we've got Cindy. She's got condition with, I don't know if I'm pronouncing this right, chrysopharyngitis and hypertrophy. Is that something?
Cricopharyngeal hypertrophy. You know, I just, without actually knowing her specific situation, I can't be certain. But there are conditions, structural abnormalities of the esophagus, and she might well have one that would not respond to Stretta. Okay. And we will often have to test for that ahead of time.
Okay, so that's kind of gets back to my other point, where if we can have you get a hold of us, we'll get you in touch with a provider. They're going to be the ones that are best equipped to help you look at your specific medical situations, get you in for a consultation, and see if this is a good option for you, and hopefully get you moving forward towards some relief for your GERD. All right, I want to thank everybody. We got a few questions that I'm sorry we did not get to. Please feel free to give us a call tomorrow. We will try to help you with those or get you connected with somebody like Dr. Reiss that can help address that for you as well. Dr. Reiss, any closing comments for everybody before we let them get on with the rest of their evening?
Well, you know, go ahead and you know, search out your options, whether it's, you know, a surgical option like LINX, or whether it's medication, or whether it's Stretta. You know, see what's out there, and you know, not all doctors will know about all the different treatments. So, you know, spend some time and you know, get the information you need. And I wish you best of luck with that.
Okay. Oh, one last comment for those that were asking about insurance stuff. We do have some information regarding insurance and some how to appeal some of the insurance decisions. We can also send you, so just contact us for that as well. Again, it's 855-855-3639. Thanks a lot, everybody. We appreciate you spending your evening with us. Have a great rest of your day.